Well, good morning, everyone. I'm hoping you can hear me. Can you?
Yes.
Yeah. Okay. Thank you very much. I hope this is going to work. Niels will have explained the kind of work we do. I've personally been specialising for more than 12 years now in the public provisioning of food. Mainly in schools and also in hospitals. So I just want to talk for about 15 minutes or so about this work, and then hopefully we can have a dialogue about your work and about our work. I just want to really address three themes: the problem, the promise, and the practical solution to a healthier, more sustainable public food system. So very, very simply, the background history to our work in the UK is a long tradition of very, very poor quality food being served in public institutions, particularly in hospitals. And that predates, that exists long before food crises like BSE and the horse meat crisis. These crises have merely made things worse. Although I often say to my students, and it's not meant to be a joke, that the horse meat scandal in the UK was probably the first time in human history when a food adulteration crisis led to more nutritional food. The cases that we saw where horse meat replaced mechanically recovered meat, as we call it, and that was a nutritional plus, even though it was called a food crisis. So this crisis has extended a long time, and hospitals now are in the forefront of the debate about healthy public food. The main barriers to reform, in our experience, have been three. Number one, what we might call the accepted wisdom, the conventional wisdom among hospital managers, among catering professionals, and so on, that good food is expensive food. That's been one of the main barriers to reform when we're interviewing hospital managers. And that conventional wisdom has been reinforced by the second barrier, which is what we call the knowledge deficit. The lack of skills among public procurement managers and catering managers about cost. If we get whole life cost methodologies incorporated in our metrics, in our criteria for buying public food, then that perception of high cost begins to disappear in our view. But the real problem has been that hospital managers have not been able to account for the health dividends of healthy food in their calculations. And this has been one of the major challenges of all, allowing low cost to masquerade as best value. And that's the second big challenge, the knowledge deficit. And then the third big barrier has been what we call organizational inertia, or the lack of leadership in public bodies to provide a lead in terms of hospital food reform. I can answer questions later about these issues, but let me just mention those three barriers first of all, because they are the most difficult barriers to reform in our experience. The key point that I often make to hospital managers is that every public institution has a food policy. Every institution has a food policy. Some practice that policy consciously by design and ensure that good food is purchased for their public institution. But many bodies practice their food policy unconsciously, by default, as we say, and allow very low quality food to enter their institution. And when they do that, in our view, they are neglecting their duty of care to their patients and to their staff. That's the key point when we engage with hospital managers. Every institution has a food policy, not just the leaders, but also the laggards, those who fall behind. So those are the problems that we've encountered when we look at public food provisioning in the United Kingdom. That brings me to the promise of reform. We believe that the benefits of a healthy public food system are multiple. There are many benefits. We call it the multiple dividend. There are benefits for patients in being able to access nutritious and appetizing food, which has a major effect on the economics of public food provisioning, because it leads, in our experience, to a radical reduction in food waste. And when you reduce your food waste, it allows you to buy a few better ingredients at the beginning of the food process. So there are benefits for patients, there are benefits for staff in terms of professional staff morale, of food caterers who are reclaiming the dignity and skills associated with cooking from scratch, cooking good food, the self-esteem and the professional pride and dignity that comes from that. Then there are the benefits for innovative suppliers who are able to provide good food at reasonable cost. And finally, there are benefits, we believe, for taxpayers. And these benefits need to be better quantified by governments and by universities, because there's a poor evidence base. The research has not been commissioned, but we believe from our own pilot studies that there are major benefits to the taxpayer once the real costs of bad food, malnutrition and diet-related diseases have been calculated as part of the overall calculation. Diet-related diseases are threatening now to bankrupt the National Health Service in our countries. We are very familiar with these diseases, not just obesity, not just diabetes, hypertension, but a limited number of cancers, coronary heart disease, and so on and so forth. When the full costs of diet-related diseases are actually calculated, we can see, in our view, that the costs of hospital food reform are small by comparison. And therefore we need to realise that these taxpayers' benefits will increase as our health services move from treatment to prevention. And I guess that's the big challenge for you, and it's the big challenge for us, to help to move a food system so that it becomes part of a preventative health strategy instead of an illness treatment service. That's the big cultural change for us all. And therefore this brings me to my third theme, which is the practical solutions to these problems. I've been working for many years with an organisation called the Soil Association, which is normally associated with simply an organic food campaign. They are the champions, the ambassadors of organic food standards in the UK, but they do so much more than just champion organic food standards. The Soil Association's Food for Life campaign is a unique campaign in the history of the Soil Association, because it's the first time ever that this body has championed food other than organic. They champion fresh, seasonal food, even if it's not organic. And the Food for Life campaign is being rolled out in schools and in hospitals. Let me just concentrate on the hospital side of the Food for Life catering mark. You can see this from the Soil Association's homepage. So I won't go into the details, just to look at the principles for now, and we can discuss it in the discussion session. The Food for Life catering mark is a simple, graduated system that moves from bronze to silver to gold standard. The bronze is the entry point for caterers and for suppliers, and it simply means a level of what we call good food, which simply means that it's free from undesirable additives, it's free from GM, it's free from trans fat, and then it moves into the positives in terms of a limited portion of organic food, for example. On bronze standard, it's a minimum, and it progresses up to silver, where you have to have a minimum, a larger minimum, and gold standard is 15%, 15% of total food spend must be organic. Now, that's a much more modest standard than what you guys are dealing with. And as I understand it from Niels, that your path to silver involves 60% organic, if I've understood that correctly. So your goal is much more ambitious than what we've been dealing with Food for Life. But even our Food for Life program is a very challenging program for hospital managers, for caterers, and for suppliers. But even though it's a difficult challenge, many hospitals now have begun this process. And I just want to mention one or two things that we have learned over the last 4 or 5 years from hospital and school food reform. First of all, we've identified a group of leading innovative hospitals who are actually already supplying what we call healthy or sustainable hospital food. And the Soil Association has created a hospital food leaders network of almost 20 hospitals and NHS food trusts, health trusts, who are leading the way in designing and delivering the Food for Life catering mark. We believe this is important because these hospitals have already demonstrated in practice that good food does not need to cost a lot more if you practice the simple principles of good menu planning, of eating within the season, of cooking fresh, just simple practices where it's based on the key ingredients of leadership, learning, and collaboration in the supply chain between hospital managers, caterers, and innovative suppliers. And seeing is believing. And it's an old saying, but it's absolutely true, because it helps to prove to hospitals that this is possible and feasible, and it's the way to go. And hospitals now are learning from each other, and learning by doing is the most powerful form, we believe, of learning. I work a lot with the City of Bristol. I'm the chairman of the Bristol Food Policy Council, and public procurement is one of our major strategies in the city, working with schools but also working with hospitals. I believe that the leading NHS hospital trust in the UK today is Bristol, It's called the North Bristol Hospital Food Trust. And you can see the details from their website. But also we have many other examples of good practice in Nottingham, in Darlington, and many other cities in the United Kingdom. And these hospitals are proving that healthy hospital food is not only feasible and desirable, but it's possible at very little or no extra cost to the hospitals themselves. And it delivers all these other multiple benefits that I've spoken about. Let me end on this simple point. I know it's difficult for us all, as academics, as caterers, as suppliers in the hospital food system. But I believe that what you're discussing today and what we've been discussing here is part of the future of enlightened and sustainable and cost-effective healthcare, because good food is now being embedded in what we call the nutritional care pathway. This has got to be the right thing to do, and it's the cost-effective way to do it. But we can only get there by learning from each other and ensuring that good practice becomes the norm and not the exception. And I'll stop at that point to see if we can discuss some of these issues, or to see if you think that what I've been saying makes sense, or whether you agree with it or not. So I'll stop at that point. Thank you.
We will hand over the phone to those who want to put up some questions for you, and I guess there will be some questions coming up already. I guess there was a number of issues that you raised that would be recognized by some of the people here. You can see the audience. I don't know if you can see the fingers, but but I can't right now. I have one up here. So you get the phone up here.
Thank you for your inspiring speech. You identified one of the barriers for better public food. One of the barriers was the leadership and the leadership of this institution. Can you fold it out a little? Is it at the management level at hospitals, or is it also in the kitchens? And have you found out what can be done to make better leadership?
Yeah. Can you hear me?
Yes.
Okay. I would say if there was we all know there are many causes for anything. So there are many reasons for bad hospital food. But I would say if there was one factor, one reason which can help us to change things, it's more effective leadership in an organization. If we can get good, effective leadership, all these other barriers can be solved. I just want to give one example. When we began this work in hospitals more than 10 years ago, we discovered that the management responsibility for food in the hospital went up to the top of the organization in terms of a department called estates. The people who are responsible for building new buildings, for purchasing raw materials like bricks, cement, and civil engineering works. In other words, food was being framed, was being defined in a way which suggested it was just one more industrial commodity like any others. And one of the first things we campaigned for was for food to be made the responsibility of the nursing manager and not the estates manager, so that we begin to frame food as part of healthcare and not part of another commodity. And when some leaders began to see this, we organised with the Prince of Wales, who's been one of our most effective ambassadors, I have to say, and he engaged with hospital managers to look at some of these ways in which food could be reframed and we could recost food as part of healthcare. And then of course, we worked with civil society organisations who were much more radical than the Prince of Wales, and they began to name and shame very bad food in bad hospitals. And that led some managers to want to raise their game, to get out of the league of the backward hospitals into the league table of the leading hospitals. So I suppose what I'm saying is, first of all, managers need to be empowered with better information, but they also need to be empowered with a political commitment to want to reform their organisation, and then we have to help them to do it practically by working with good suppliers and others. I don't think there's any substitute for good leadership from our work. That's the most important factor of all.
Thank you for this.
Do you agree, by the way, or not?
I think there's been nodded here around here. We have one more question, Kevin, before switching to the next presentation. So I'll hand it over to the next.
I'm really touched by the way you talk, and that is about what I have been working with for the last 14 years. It's exactly the same thing, so I'm really glad hearing you speak like this. I want to know, have you been measuring the nutritional effect on patients?
Can you hear me okay?
Yes.
Yeah. In our own work in my university, we have not personally been measuring the nutritional effect. But in some parts of the National Health Service, for example, in Cornwall, the Cornwall NHS, which is the southwest of England, the region, in Cornwall they have been measuring the nutritional effect. And when they've moved to more seasonal food, fresh food, cooking from scratch, and more locally sourced food, they have managed to secure the highest patient satisfaction rates for their food in the entire NHS. So that was the first thing they measured, satisfaction rates from the point of view of the user or the consumer. And then they began to measure the nutritional effects. In my view, that hasn't been done enough, because enough money hasn't been invested by the government in looking at the nutritional dividends. But Cornwall has already received some encouraging feedback, but it's not robust enough in my view. As an interim measure, we are measuring consumer satisfaction rates from hospital food and the level of take-up. And that, in my view, is a good indicator until we get better data on nutritional impact. That, in my view, will come, but we need more investment in the research base.
Okay. Thanks a lot, Kevin. I think we have to finalize your presentation here, but thanks a lot for being with us. And I would suggest the audience to give you a big hand here. Thank you very much.
Thank you very much.
Thank you. We'll talk later.
Have a good day.
Yeah. Thank you. Bye-bye.
Bye-bye.